I'm presenting this on behalf of the permanent secretary who has become engaged. She was supposed to open our session here. It is our pleasure to welcome all of you, the participants, to today's session, which is very key and very important on emergency care, an essential component of universal health coverage. In this session, of course, mainly when we planned this, we thought we could be able to meet physically, but we are meeting virtually. Nonetheless, we say you are most welcome. And I want to say that a panel of experts has been assembled to share their knowledge and experience on emergency care from the local level here as a country, Uganda, at the regional level and at global level. The government of Uganda has prioritized the integration of emergency care into the national health care delivery system. And we are pleased to share our experiences in that regard. We are looking forward to sharings from other regional and global partners who are working in emergency care, and also to hear from the participants on what they are doing in emergency care. It is my pleasure now to introduce to you the esteemed panelists. We have Dr. Terry Reynolds from World Health Organization. She heads the unit on acute care and trauma. Dr. Terry, you are welcome. Then we have Mr. Tore Louden, who is from private sector, the Ladder Foundation. We have Dr. Annette Alenyo, who is the president of the African Federation for Emergency Medicine. We have Dr. Priska Kizito from the Emergency Care Society of Uganda. And then we have Dr. Bonaventure Aisiwe from the Seed Global Health. Allow me, therefore, to hand over this session to the chair, who is Dr. Terry, to take us through the session. Thank you, and you're most welcome.
Great. Thank you very much, Commissioner, and welcome, everyone. Thank you for joining us this morning. So this is really an opportunity for us to speak with each other and also with you. The goal is to look at emergency care strengthening as a process with a focus on the Africa region, and to look at it from multiple different perspectives. So what are the kinds of actions governments have taken, foundations have taken, professional societies at both the international, regional, and national level. And then also look at what organizations like Seed Global Health, who've actually engaged on many different levels, and how each of these actors has decided to focus on this area, and what have they found to be successes and challenges to that work. So what we'll do, we'll spend the first part of this asking a few questions of our panelists, and then we will open it up to audience questions for you. And feel free to put questions at any time into the Q&A chat, and then we will gather those together and put them to the relevant panelists in the second part of this. So if you have a particular panelist to whom you would like to address your question, identify that also when you submit your question, but feel free to just submit a question and maybe multiple panelists will have the desire to answer it. And so with that said, let me go ahead and start with the first question. Commissioner, this one is to you because you gave us a little bit of information in your opening, but we'd love to hear more from you. So several years ago, Uganda took a very explicit strategic decision to sort of work on emergency care strengthening and to prioritize that work. So tell us a little bit about that process and why that happened for Uganda, because not all countries in the region have made such an explicit decision to pursue that. So tell us a little bit about the process, what you went through, and then how it links up to Uganda's overall vision for universal health coverage, for progressing towards universal health coverage. Over to you, Commissioner.
Yes, thank you, Dr. Telly. From way back in 2015, Uganda initiated the emergency response system. It came suddenly when there was supposed to be a visit, and the Minister of Health decided to procure about 10 ambulances. From that learning, they saw that if we had some organized system, we could be able to respond to emergencies. So in 2016, the Department of Emergency Medical Services was formed. And in 2017, we linked up with the WHO Geneva, who supported us to conduct an emergency care system assessment, in which we identified the key gaps in the emergency care chain, and also developed the national priorities for emergency care. This process involved many players in the private sector, all the government departments, and also in the private not-for-profit sector. And it was informed by the fact that most of the, when you look at the annual health sector performance reports, you find that the 10 causes of mortality in the country, 7 of them, the seven of the topmost causes of mortality in the country are presenting as emergency conditions. And we noted that only 7% of the emergency patients actually reached hospital using ambulances. And we had a high maternal, we still have a high maternal mortality ratio, a high road traffic accidents, and so on. So this informed the process. So after that, the 2016-17, the government of Uganda decided in the health sector development plan and in the presidential directives to prioritize emergency care. And one of the key areas which the emergency care system assessment identified was on issue of system organization and governance and finance. So we set out to reorganize the system, and I can say that we came up with a policy and strategic plan which kept guiding us. We went up to also develop the emergency care data elements into the DHIS2, and also issues of scenic care, transport and transfer. We had to focus on these areas. We decided that as the approval of the policy takes place, we should take on the issues of implementation. So we were training the paramedics. The course of emergency medicine started in the universities, and also training the first responders, the police and the others. And we started also on the issue of establishing call and dispatch center and the regionalized and coordinated ambulance system. So this is where we are moving from, and this falls rightly into the national universal health coverage, in which if we address these emergency conditions, then we are able to reach many people who cannot be reached. And because of this, we also provided in the Road and Traffic Safety Act of 2020 that people with trauma who need emergency care, who access private and also other health units, should not be denied care because of inability to pay. So that helps us to reach the universal health coverage goal. Thank you.
Perfect, Commissioner. Thank you very much. That's super helpful to hear about your overall approach, and also the details of the kinds of activities that you have undertaken. So let me go now to Dr. Kitsito Priska, from your point of view, which is you're acting in the same system from a very different perspective as the lead for a national professional society. So of the things, both from your perspective as a sort of first contact clinician and also as the leader of a national professional society, how have these decisions that were made at the ministry, how have those been operationalized in your experience, and what's the role of the professional society? And then I guess as a background for that, we'd be really interested to hear, what is your sense of the state of emergency care in Uganda now? Because it's one thing to do kind of a high-level system assessment. It's another thing to hear about the reality from someone who's working at the first contact level. So over to you, Priska.
Thank you, Terry. I guess I should start with what do I see as the state of emergency care now, as a frontline clinician and also a president of a society. I would say it's taking form, because we've come from a place of no EMS to talking about it, and now to hearing things like regionalization of EMS and then national EMS system. That's at the point of practice, from the top management team to the lower levels. We've also come from a place of having dispersed resources and emergency care being practiced in different levels of care, but not hearing about it. But now we are hearing about KCCA or Masaka or Mbarara, all these different centers practicing emergency care in a way that we see effects at those different levels. So it's taking form. In addition to this, I think as a society, bringing on board society has been instrumental in bringing different teams together, in both those that are managing and creating all these policies, creating the Department of EMS, to those that are going to utilize it. So it has given direction and provided some sort of technical advice or support to enable that the Ministry of Health agenda in setting up the EMS system actually happens at the lower health centers and among different cadres of healthcare. Yes, so I think this is actually being operationalized, but although at lower levels we still have work to do, but you can see it at different regional referrals coming through. Thank you.
Great, thank you very much, Priska. And let me just come back to you for so there are a lot of countries in the region who would like to establish or advance existing professional societies. What kinds of activities has your national society undertaken? And what kinds of activities do you think national professional societies in particular are well positioned to contribute to? Over to you.
So in terms of what the National Society has been able to do, based on objectives, we've been able to sit on the same table with the partners, both government and non-government organizations, to enable that the agenda in achieving the emergency care as part of the UHC takes place. So we sit on the same table, we are able to provide direct feedback, we are able to provide support in terms of technical advice, but also having a professional society that has different cadres, not just specialists or just nurses in silos, makes it easier because you hear from different angles and you implement things and advise the top management team in the best way forward, involving everyone else so that there is ownership. So I think what's unique to the Emergency Care Society of Uganda is that we are able to link national policymakers, and then the implementers and the utilizers. And some of these are patients or people who have experienced emergencies. So if you're forming a society, it should be able to bring together everyone, from those that are high up there to the lowest person down, utilizing resources that are set up. And also it should be able to link the national and the global teams. So that you're able to implement now whatever trickles down from WHO in an easier manner while acting as the center of advice. So I think that has been quite useful from the society. The other things that we've been able to contribute to are helping to streamline scope of practice for different cadres, and that still comes from the fact that these people are in the same seating at any one point. So if you're discussing things, the people who are going to help set that policy forward are listening, and also those that are going to maybe sit on councils to license, or even the people who are going to be studying, educationalists, and then researchers are also in the same group or sitting to enable you to get views from different people at the same time. Yes.
Fantastic, Lucia, thank you very much. And so now I want to come to a complementary perspective on the professional society and come to Dr. Leño. Annette, you were previously the president of the National Society, but now are the president of the Regional Society. And you have been engaged in for a long time in this government strategy on emergency care. And you also were very involved in advocacy around the WHO Resolution 7216 on emergency care. And given these higher level strategies, what do you see as the optimal role of professional society, both regional and national, to help improve access to emergency care? Over to you.
Thank you very much, Dr. Terry. So professional societies and organizations such as the African Federation for Emergency Medicine are key stakeholders in healthcare. They represent all cadres of healthcare, serving in all sectors, be it public, private, and also non-governmental organizations that are all together pursuing a common agenda of improving access to quality emergency care. So professional societies specifically should work at promoting partnerships and collaborations between healthcare professionals and their organizations at all levels, as you've clearly said, at national, at regional, and at global level. They should also closely work with ministries of health and other pertinent government ministries and agencies. The other thing that they should do is work with other stakeholders at national and regional levels, including UN agencies such as the World Health Organization, university research.
Excuse me?
Yes.
Yeah, this session is live on TV, so if anyone is speaking, they should keep their videos on, and preferably if you can all keep your videos on, so that we don't have to get on TV with our names. That would be perfect. Yeah, thanks. Yeah.
Thank you. I am just confirming that my video has been on and it's on.
Thanks, Annette. Please go ahead.
Great. Thank you very much. Working with stakeholders at global, national, and regional levels, including UN agencies such as the World Health Organization, university research networks, donor agencies, non-governmental organizations, and really all organizations sharing a similar agenda. They should also, as far as an agenda is concerned, pursue a common agenda to address specific issues related to accessibility of emergency care at all levels, again, national, regional, and global. The other role that professional organizations should focus on is advocating for and championing emergency care. Further, they should encourage and support both national and regional collaborations among healthcare professionals and their representative organizations to promote emergency care at all various levels. And finally, assuring that healthcare professional organizations continuously play active roles in both national and regional planning, implementation, and monitoring of programs to improve emergency care. Allow me conclude by calling on all stakeholders and participants in the World Health Summit and reminding us that establishing effective and ongoing working relationships between government, development partners, and healthcare professional societies at all levels is essential to us addressing the continued tragedy of preventable deaths from time-sensitive medical conditions and trauma. We therefore ask that ministries of health, government agencies, United Nations agencies, universities and research networks, and non-governmental organizations, even donor and developing agencies commit to this call. This commitment will entail inclusion of healthcare professional organizations at all levels in planning and implementation of programs and initiatives through partnerships for improved and accessible quality emergency care for all citizens. Thank you.
Annette, thank you. That was fantastic. And let me ask you, within the categories, so you mentioned a number of categories where professional societies at different levels can be effective. Can you just, because I know you've had a lot of experience with different activities and these roles over the years, just give us an example. What is one of your favorite examples in any of those areas, really, either in terms of collaboration across country boundaries or in, say, advocacy? Just give us a quick example of one of your favorite success stories where you have succeeded with such a collaboration or with advocacy across to other stakeholders. Over to you.
Terry, believe it or not, one of my favorite success stories is using social media. And for us, it has been WhatsApp. A very simple tool, a simple social media application that is free and that is available all over the world, but mostly in low resource settings like Uganda. It is something that we often use, and not just Uganda and other African countries. It is something that is often used for people to network and discuss with one another. Now, what professional societies have used, and this is also at national level with the Emergency Care Society, but also at the level at regional level with the African Federation for Emergency Medicine. We've harnessed this simple tool and its strength in connecting people all the way to grassroots. You don't need a lot of data. You need just to have a simple smartphone and download an app. And thereafter, the interactions is instant. It cuts across so many people, all the way from the lowest level, from the community level, all the way to global levels. What we've done in many of these WhatsApp groups, speaking to the African Federation for Emergency Medicine, we've got people cutting across. So all cadres of health workers are represented. We have nurses, we have doctors, we have EMTs, we have advocates, we have administrators, we have people across the continuum of emergency care coming together in one pot of, on a WhatsApp group. And whenever there's an issue to be addressed, there's also, in addition to representation at different cadres, we also have geographical representation. So we have people speaking in from perspectives all the way from a small rural health post somewhere in Africa to a bigger facility, a national referral, regional referral hospital, but also to regional and global level organizations and groups, having different perspectives to address one issue, be it implementation of a simple thing, or be it advocating for an act or a policy. I think it allows us to have different perspectives, to support one another, and to eventually come out with better products than I initially designed. And for me, that has been an incredible success story. And through these WhatsApp groups, for example, in Uganda, we've initiated discussions that have flown and gone all the way to the ministry level and have been taken up by the top management at the ministry. And I'm sure this has been reflected in other African countries. So a simple tool achieving very big impacts. Thank you.
Excellent, thank you. That's a great example. So now I want to look at this from a slightly different perspective and come to Dr. Ahisibwe. So Bonaventure, you represent Seed Global Health, and it's particularly interesting the way that Seed has chosen. So Seed first has chosen emergency care as a focus, and I'd be interested in knowing how that happened and how you came to that priority focus. But also a lot of policymakers and funders have traditionally focused on vertical programs or individual diseases or specific subpopulations, frequently maternal and child health. What was it that sort of led Seed to focus on emergency care? And looking at that decision now, 18 months, or so into a pandemic, how has that, what do you think now about that strategic decision? Because interestingly, emergency care has become increasingly visible now, but this is a decision that Seed made well before the pandemic. And in particular, if you can give us a little bit of information about how, Seed has chosen to act at a number of different levels, ranging from policy advising all the way down to direct support for the delivery of clinical care. So how did Seed make that decision? Looking back from this late pandemic phase, how is your perspective on that change now? And why and how did you decide at what level of the system to act? Over to you.
Thank you, Dr. Terry Reynolds, and I hope you can hear me loud and clear. Thank you so much. So for the benefit of our audience, if there are folks that are not extremely familiar with emergency care, it's essentially the little interventions that are in place, be it in the community or at a hospital level, to try and save a life or prevent irreversible disability just in time. And to that end, to your question, Terry, we did have an opportunity to do a little bit of a strategic shift from previous times when we've had specific investments in, let's say, TB, HIV specific diseases, and did recognize that there was a special opportunity in emergency care, not only as an entry point into the health system, but also we did realize that investments in emergency care do have a ripple effect that also supports investments in other areas of the health sector. We did have a national open day for emergency care 2 years ago at Mbarara University. And I shared this story of a 2-year-old boy called Emil Owamono in Guinea. This little boy showed up at the health facility with dark stools. He was treated as presumptive malaria and went back home. He only got to be known as patient zero for the West Africa outbreak when 3 of his family members passed on, and this outbreak went on to cost the world $53 billion US. 6 countries, 3 continents. It was enormous. It brought the health sector to its knees in many countries. But if this little boy had gotten the right attention in the right time, if it was the right protocol, right index of suspicion, just that encounter could have saved the world $53 million US, saved the lives of 163 health workers, saved us a lot of the inconveniences that we saw and protected the gain. So in many ways, what I'm saying is that there's an opportunity by investing in emergency care to future-proof the health system and make sure that it is resilient to some of these mass effects that we have seen, for example, in outbreaks like COVID and Ebola. And further to that, we know that the core of emergency care is decision-making, that someone who sees, for example, that 2-year-old boy need to make the right call. Otherwise, it ceases to be emergency care. You have a limited window of time and you need to make the right decision. So to that end, having the right people with the right attitude and skills in the right place is fundamental to driving emergency care. And our core investment has been in partnerships with training institutions to ensure that a cadre of pre-service and specialist trained emergency care providers are in place to be able not only to deliver emergency care, but also to go ahead and teach emergency care and also provide leadership and advocacy for additional investments in emergency care and the entire system. The other piece, though, in terms of engagement, you realize that Seed Global Health does invest not only directly in care, but also at policy level and also in at the system level and at the direct frontline care role. We did realize that to sustain and bring together some of these innovations and best practices, to be able to bring them to a scale that is able to be sustained across both the country and the continent, the decisions made upstream at policy level and also budgetary appropriation need to be in support. The people who decide, for example, in Parliament, at the Ministry, in Ministry of Finance, need to understand that this is important and see a reason to invest in it. Otherwise, these small best practices will remain as small best practices and will not be able to scale and sustain. And then also finally, you realize we have a lot of ambulances procured as part of the COVID pandemic, but it may be pointless, for example, to do a very good evacuation from the community and take someone to a hospital where they're going to spend 9 hours waiting for definitive care because you've lost the window to actually reverse possible disability or even save that life. So to that end, much as folks who are not directly investing in emergency care may not necessarily want to spread themselves too thin, it's important to do some policy, some advocacy to ensure that the definitive care in the other departments and hospital settings is available. Otherwise, emergency care is not an end in itself, it's a means to an end. So we need to ensure that the environment or the destination departments or units are empowered to be able to create that environment so that we can both improve the quality of life and also save lives. Thank you, Terry. I'll cap it at that for now.
Thank you very much, Rich. Let me ask you just to add one very quick thing to that. Because SEED works on such a wide scope of kinds of activities, give us a quick example, just a concrete example of the sort of highest level activity that you might have worked on, something that's in the really top level in terms of, say, at the policy, and then one of the more macro, rather, not necessarily the top, but one of the more macro things you've worked on, and at the total other end of the spectrum, one of the most micro things that you've worked on. Over to you.
Thank you much. I'll start with the micro because sometimes little pieces can actually shed the light that or open the path that actually leads to much bigger conversations and investments. So the micro piece I'll look back to is open day for emergency care for medical students at Mbarara University. It was a simple get together or conference organized by students, and they decided not only to do it for students, but also invite policymakers, educators, and other people. A lot of the conversations that started there have had a ripple effect that has led to much bigger conversations. One, in terms of bringing together the major training institutions that are training emergency care across the country to harmonize curricula and look at competencies to be sure that they are organized, they're aligned and speak the same language. And when you have an emergency care physician, you can comfortably say this person has this competence. And it started as a small table talk conversation on an event organized by medical students on the sidelines of the General Assembly. That was micro, but it has had the opportunity to open the door for much bigger conversations. At a more macro level, I think we've had the honor to collaborate with the Ministry of Health in highlighting the importance of emergency care. And to that end, there's a national review of structures for health workers placed at different levels in the health sector to ensure that emergency care is integrated in that for a process that happens once in 15 years. is a great opportunity to scale out both staffing and competence for emergency care practitioners across the country. So I think I'll just give those two as examples at a national and institutional level. Not to say that any is less important than the other. So I just deliberately shied away from calling it micro or macro. Thank you, Tim.
Fantastic. That's a perfect example. Thank you very much. So now I would like to come to an international foundation, Referral Foundation, and to Mr. Toure Lerdahl. And Lerdahl Foundation is known around the world, right, for its work in both resuscitation education and also resuscitation science. How did it happen that you came to focus on this area in general, but also with your more recent shift towards health system strengthening and engaging those kinds of activities? And then what do you think is the specific value added of a private international foundation? So what are the key kinds of actions that an international foundation can take relative to the kinds of other actors that we've heard about? In other words, the ministry, the regional and international professional societies, an organization like Seed Global Health. So how did you choose this focus, and what is the specific value added of your kind of organization? Over to you. Toure, sorry, we're not able to hear you. I'm not sure if it is a mute issue or.
Chair? Hello, Chair?
Yes. Toure, yeah, Godfrey, are you able to make sure that Toure has the mic open capacity?
I can see Terry has the microphone. Terry, can you speak?
Yes, I'm speaking
Thanks,
now. Okay, yeah, so it seems that the sound has gone for multiple participants. Are you able to hear us now?
I can't hear Terry. I can't hear Tori. I can only hear you, Terry.
Okay, so let's do this.
I can see it is audio. It's connecting to audio. It's just coming audio.
Great.
Yeah, hope
So,
his audio is
I will give you just a moment to connect to audio. And
yes,
then
the other thing, Terry, Dr.
Yeah.
Terry, Chair, I can see there is a hand up in the attendees. So you would also look into there in case you want them to speak or you want them to say something. Yeah.
Sure, that sounds great. So let's see, Toure, do you want to try to speak again and see if you're able to? I believe he's connecting to audio. So let's do this.
Can you hear me now? Can you hear me?
Yeah, now we can hear you. Great.
I'm so sorry about this. Anyway, hello there,
That's
Terry.
no problem. Yeah, did you hear the question? Okay.
I heard the question perfectly. Thank you so much. And I do
over to you.
apologize.
No problem.
Good morning, everyone, panelists and audience. I'm very pleased to be invited to participate in this panel. And to give you a little context, Lerdahl has been very much part of resuscitation training since the discovery of modern resuscitation techniques around 1960. It's estimated that over 500 million people have been trained in cardiopulmonary resuscitation. And there is an obvious connection, tie between resuscitation and emergency care. For SDG3 to be achieved, there is a need to reduce the number of so-called untimely deaths by about 16 million people per year from 2020 to 2030, or proportionally about 8 million in the decade we have just started. And there is a common denominator to these untimely deaths, and that is that for multiple reasons, the oxygen supply to the brain stops or is severely compromised. And that may be caused by sudden cardiac arrest, so that the heart is not pumping blood. It may be caused by drowning, by suffocation, by road traffic accidents with massive bleeding, by disasters, by also a stroke that is compromising the blood flow, or by complication at birth with a newborn, not the breathing at birth, or with a massive bleeding for a mother. So the common denominator is, in all of these cases, that we need to restore quickly the oxygen supply to the brain. And since time is so much of an essence, the entire population need to be part of a healthcare system. There need to be a bystander that recognizes that something is now happening and is calling, is not delaying the call for help. There need to be a dispatch center that is qualified to handle that call and to dispatch help to the sites, and at the same time to give instructions to the caller of what the caller can do, the bystander can do, why help is underway. And all these 8 million deaths, most of them, actually as much as 85 to 90% occur in low, medium income countries. And that is settings where there are particular also logistical challenges, of course, with the healthcare system, with shortage of healthcare workers, with poor road systems, with less training than in high-income countries of the general public in CPR and other appropriate steps. So the whole challenge here is to address the entire society and establish a emergency care system, or it takes a system to save a life. And so therefore, with the goal of helping save lives, it was pretty obvious for the Lerdahl Foundation to widen its scope from resuscitation to all these death categories I mentioned, where life is at the stake due to compromised supply of oxygen to the brain.
Excellent, thank you. And so just as a quick follow-up, similar to what I have asked of the others, give us a couple of examples, because Lerdahl has engaged this also on multiple levels. The foundation has engaged this topical area of emergency care in many different ways, sometimes as a funder, sometimes with scientific contributions. So give us a couple of examples that are quite different from each other of how Lerdahl has executed this priority of strengthening systems to deliver emergency care. Over to you.
Yeah, we have been privileged to convene or to help support a number of expert conferences, so-called Outbreak meetings, and we are delighted to work also with the WHO now to prepare such a meeting on emergency care systems. And the goal of these conferences have been to establish best practice and to define ways of measuring to improve, because you do need a registry, you do need to know what's going on to be able to improve the system. And that has resulted in templates for how to measure and report on system assessments. And in general, I think, as is often referred to in global health, you have a survival opportunity or a chance that is defined by a product of 3 factors, the so-called 3Ds, which is discovery, development, and delivery. And there is, I think, a growing appreciation that it's in particular delivery that is the weakest of these 3Ds. So it is not only having the knowledge of what to do and having the educational systems on how to train providers, but is very much about the system approach to a quality implementation of the program. And it's also shown that more patients are dying from poor quality healthcare than from lack of healthcare. So there is a very, very good reason to try to integrate the various efforts and elements of the healthcare system. And in that context, I also think the private sector and foundations like ours and others can offer some help in public-private partnerships to improve both the delivery or the implementation and the system follow-up.
Great, thank you very much. So listen, at this stage, we will move shortly to another round of questions to our panelists, but I just wanted to pause for a minute and pass on a couple of questions that have come into the Q&A. If people have questions, again, please put them into the Q&A chat. But since there's a couple that address the issues from this round of questions. So let me go ahead and take those now, and then we'll come back to more questions to the panelists. So this is a question to start with for the commissioner. In Uganda in particular, can you give us a sense, even estimated, of what proportion of the population would you say have access to emergency medical services? And so that would be kind of logistical, physical access, or the ability to get care when they need it. And then a second question, what are the specific mechanisms that are being used to ensure that those services can be accessed and utilized without requirement for payment prior to care? So two separate questions. What proportion would you estimate have theoretical access to emergency services? And then specifically, what mechanisms have you found effective in Uganda for ensuring that they get care without a requirement to pay prior to services? So over to you, Commissioner. I think that's probably one for you as a first step.
Good. Thank you, Dr. Telly, and thank you, participants, for the questions. Dr. Olive gives us the question on access. Generally, my estimation of the current access goes way towards a third, about 35% of the population could be accessing emergency medical services. This I'm basing on more about the physical access in the sense that we have been able to establish regionally coordinated ambulance system in all the 14 regions, and we have placed in there an average of about 6 to 10 ambulances per region. We have had some trainings for first responders, especially the police, the village health teams, working with partners like Uganda Red Cross, like COFI, the Korean Federation for International Healthcare, and the others. We have been able to train some of these first responders. So in terms of physical access, based on data distribution and first responders, I estimate it at that level. But you know, our targets are not yet met. In terms of financial access, it is on the next question, but I want to say there is still a limitation there. But at national level, we make sure that fuel is provided for these ambulances, and mainly for response to those critical cases which people may not be able to have ability to pay for them. In terms of social access, it is still difficult in the sense that, of course, many people, about 70% of people would like to use our ambulance services, but then there are those who may not want to use either an ambulance or go to a health facility for reasons which are best known to them. The mechanisms, on the second part of the question, the mechanisms which we are using to ensure that people are not required to pay in order to access emergency care. We have been, this is work in progress, but we have been popularizing this act. It is now a requirement that private facilities, government facilities, and so on should give the first care just to preserve life before you refer a patient to another level. We are going ahead with the Ministry of Works and Transport and all the interested parties to develop regulations to the act so that we can be able to functionalize them. And the biggest challenge has been private sector asking the question, how are you going to compensate us if we attend to maybe a critically injured patient and the first care to save life is very expensive? And these are the areas which we are trying to discuss. Thank you.
Excellent, Commissioner. Thank you very much. That's a very clear account of challenges that you're facing, and I think it's particularly helpful because there are a number of countries, both within and outside this region, that are facing similar challenges. So this is not unique to your country or to the African region. But there have been a number of successes through exactly the kinds of pathways that you're talking about, through a variety of regulatory mechanisms. Good. So let me, with that, go to a second quick round of questions to our panelists, and I'm going to take them in a different order this time. And very similar questions to all of you, but that I think will have quite different answers because of the different organizations that you are leading and belong to. So let me come first back to you, Prisca, to Dr. Kizito. And from your perspective, again, as the lead of a national society, but also as someone actively working in first contact emergency care, just quickly, what has been effective so far, and what is at the top of your list if you were asked to identify what's needed, what's most needed right now to strengthen emergency care? Over to you.
Thank you, Terry. What has been effective thus far has, I think I can start with formalizing training in emergency care. And by this, I'm talking about master's program, diploma programs, and then pre-hospital care training, in addition to basic emergency care for different cadres of healthcare. And this somehow has put emergency care on everyone's lips, because then they learn, they effect what they've learned, and then we get to see results and testimonies from patients. And then the other thing that has been effective, I would say, having set aside a department of EMS kind of woke up weaknesses in the system, and so enabled us to get some prioritization of emergency care from word go. Maybe if we didn't have any sort of EMS department, then we wouldn't have any actionable plan to use. So having that set aside. And then the third would be that a professional society that sits on the same table as the people who set policies and those that implement, and then those that utilize those same policies, is the other thing that has been effective in ensuring that things are done the right way. And if they are not done the right way, somehow there is a backflow of information that enables correction of those things. And best example for that is like the misuse of ambulances, which you just basically take a picture, share on a group, and somehow people are out to push for what's better, how the better use of such resources. And then finally, of course, having partners that think the same as the society, the government, and have a similar agenda at a national level and also at the world level, meaning World Health Organization, reaching out to enable collection of data to ensure that whatever we do is evidence-based. So people like SEED, Coffee, like Dr. JB has mentioned, and all these other partners, Malteser, in addition to the many that I haven't spoken about. And these have given us momentum in a way that we want emergency care to be effected even at the lowest level, even if we don't have all the resources, the 15% budget of healthcare awarded as yet. Yes. And then what needs strengthening to me would be formalizing emergency care as part of the minimum healthcare package for all Ugandans. I think once that is clear, then priorities would be set aside for emergency care from the people who lead us in this country and allocate resources. So if it's clear that it has to be part of a national insurance policy and a minimum healthcare package, then we shall see our priorities right in regards to that. And the other thing that I would think needs strengthening would be public involvement, more public involvement in these same policies. So we speak a lot at a professional level, at government level, but what about the people who actually use them? They are involved, and then I think if we still have no policy approved, we still have a lot to do with setting our priorities right. So an EMS policy, a proper strategic plan with a monitoring and evaluation unit to see that whatever we've implemented as, let's say, a professional body or even Ministry of Health Uganda together, then we shall see that everything is working and is measurable in regards to emergency care. And finally, incorporating emergency care in curricula at all levels of education, meaning undergraduate and higher education and pre-hospital and in-hospital, and then incorporating that same emergency care in both, in not only pre-hospital, but also in-hospital. Once there is that link between pre and in-hospital, lower levels of education and high levels of education, I think everything will be in sync. Thank you, Terry.
Excellent. Thank you very much, Priska. That was a very articulate survey of all of the levels of action, actually, that can be taken and that many countries are trying to engage. So that was a very masterful scoping of the field for possible action. So thank you. Dr. Alenyo, Annette, let's come to you, and really very similar question. What's been effective so far? What's most needed? And then in particular, based on, I'd like to ask you to focus on, based on what you've heard today from the different people on this panel, and the ways that they can act, what are some opportunities for effective action from your perspective in the near term? Over to you.
All right, thank you very much, Terry. And I'll start with what is most needed. And for me, I think without even skipping a heartbeat, that has got to be leadership. We need committed, dedicated leadership that understands the gaps and is ready to work towards filling the gaps. And the role of leadership for us has never even been more critical or more evident than during the COVID pandemic. It has shown us the importance of having proper leadership. But in answering this better, allow me to directly quote from science, and I'll quote from an abstract of a late release article that has been done by a group from the International Federation for Emergency Medicine. And this article is entitled Leadership Matters. It's a needs assessment and framework for the International Federation for Emergency Medicine Administrative Leadership curriculum, but it does speak to us in our different contexts. So Dr. Yanis Stupesi et al. In their conclusion wrote, and I quote, the results of this study further support the findings that the majority of emergency care providers who were queried during the study do not have a longitudinal curriculum that fosters administrative and leadership development, nor advocate for its importance in relation to the quality of care. Given this gap, we propose that medical education at all levels, medical schools, emergency medicine residencies, specialty training programs, and professional organizations should consider creating administrative and leadership development programs. Additionally, development of any curriculum should require a global understanding of healthcare systems and awareness of the unique context of a given location and its available resources. Believe me, without leadership, a lot of what we will think about, what we want to do, either stays on paper or stays in our minds as wishful thinking. We need leadership that is committed and able to translate a lot of the principles and global lessons from various health systems across the world that are trying to improve their emergency care services. And for this, I'm actually very excited that Dr. Wanyai, the Commissioner for Emergency Medical Services, was included in this panel discussion. Now, as far as opportunities for effective action, well, I believe that having strategic conversations like we are having right now on emergency care, and conversations that bring different perspectives within a system together are very important. They allow us to talk, yes, about the big picture, but also for us to ask the big questions and the small questions that are pertinent to us building a sound emergency care system that is able to respond to the community's needs. Because at the end of the day, whatever we are doing has to translate into that single person deep in their community. I'll give an example of Amanyata in Karamoja. It should translate to the level of a woman in labor in Amanyata being able to access the emergency care system and have a safe transportation and safe delivery with a good outcome for her and her child. That is as small and as detailed as we should go, because whatever we do, it has to be effectively translated to the end user. So moving forward, I believe that being on the same page about the current landscape, what has been done and what still needs to be done, will allow us to have better policy and strategic direction. It is an opportunity to also think more critical about our training and education, the different curriculums that we are rolling out and their delivery. Are they speaking to the emergency care challenges that people in the community are facing? It will also help to align our research agendas. And this is a very big opportunity for researchers. They've been on call. You've heard the different issues that are being brought up, the different approaches and different viewpoints. So our research agendas should be more relevant and more aligned to filling the gaps and that exist, but also to strengthening the different aspects that exist. Moving further, for us to have more strategic and stronger collaborations, our partnerships, our collaborations should be stronger and more targeted towards pursuing a better goal. And finally, to improve advocacy and attract more funding. So donors out there, this is an opportunity. You've had the gaps, you've listened to the discussion from all different viewpoints. There are so many opportunities for improvement for all these various stakeholders. So thank you very much. Back to you, Terry.
Thank you very much, Annette. And somehow it's very easy to feel that the future of emergency care in Uganda is in very good hands, listening to your answers and Priska's answers. So it's really a pleasure to see the two of you in the leadership of these organizations and so effectively bringing us all together to really have impact. So let me jump now again to Mr. Lerdal. So I'm curious about, I'm interested in general, what do you see as opportunities for effective action, but in particular, how do you see your engagement in emergency care changing in the future as you go forward? And is there anything that you've heard here today that that affects that has opened up new possibility for you in terms of how the foundation might engage? And what is the evolution of your vision for this? As you mentioned, it's changed quite significantly over the past couple of decades, but what comes next for your horizon of engagement with emergency care?
Well, thank you. I think both Priscilla and Annette gave some great answers to your question. And I see perhaps three main points that I could add to what they said. First, although it was mentioned, but even more so, there need to be awareness. There need to be mobilization of the community, because 80% of these deaths occur outside of the hospital. They occur suddenly, unexpectedly, and a bystander must be able to appreciate that that help is needed. So, secondly, that there is a need to focus on the lowest hanging fruits. Some deaths are not as dependent on a complete chain of survival with follow-up treatment in hospital as others. For instance, if you have a primary respiratory arrest, which would be the case of, let's say, birth asphyxia, of drowning, of suffocation, a patient falling unconscious in a road traffic accident and the tongue is blocking the airway. In those cases, all that is needed is some simple steps to open the airway and, if necessary, stimulate the patient and maybe give some mouth-to-mouth resuscitation. And that could save the patient. So I think there is a need to focus on the lowest hanging fruits, and generally early interventions are needed, because it's getting more and more complicated, and the patient's prognosis is poor as time is going on. One more point is enabling technologies. Now with the digital revolution and the ability to really leverage mobile phone technology, I think there is an opportunity to improve communication between the caller and the dispatcher, and to have a more accurate understanding of what's going on at the scene, and to dispatch the right help, and also to provide some advice over the phone while help is underway. And the final point is partnering again. I think public-private partnerships and leveraging what we know works, and trying to apply the best practice and not reinventing the wheel. So I applaud the initiatives of getting this topic on the agenda for this conference, of the resolution of the World Health Assembly. So that shows some promise that more attention is given to this field, as is very much needed, because there are tremendous opportunities of saving more lives. Thank you.
Perfect. Thank you very, very much. And since you have mentioned the need for visibility in this, I want to come now to Dr. Aizibwe and ask a couple more questions about feed, and then Commissioner, I will come to you at the end. And just so to tee it up, I'm interested in your thoughts, Commissioner, next about what has been the effect of the resolution. A couple of people have brought it up, and how has that served your activities? But first, to you, Bonaventure, what has been effective thus far, and then what's needed most to strengthen emergency care in the region? But also, how do you see SEED's engagement? As we talked about, SEED is engaged really from very micro to macro. How do you see that engagement evolving and changing really in the medium to long term? Is there any different approach on the horizon for SEED with regard to emergency care, or is it more executing the strategic agenda that you've set forth already? Over to you.
Thank you so much, Terry, and kindly confirm that you can hear me loud and clear. Thank you so much. So just speaking after particularly Dr. Priska Chizito and Dr. Annette Alenyo, really is testimony to how much energy there is among a number of players within this space to change emergency care at different levels. And I think that speaks to how much mobilization has happened and how much the reality on the ground between COVID and trauma and other pieces, how much a reality on ground has done its legwork to emphasize the need for emergency care. I want to invest a little more time in speaking about where the opportunity is, given that there's a lot of momentum. I could use the whole day to sort of like celebrate that. But I think particularly, and I've said this before in a couple of platforms, we need to invest more. We definitely need to invest more, and the time is now. COVID is a warning, there is more to come. I'm not a prophet of doom, but we've seen this coming for many years. We know that success is where opportunity meets preparedness, and we cannot afford to leave our rear exposed, waiting for the next calamity to happen. So I think this is the opportunity. The whole world is very forgiving of any mistakes that happen because it's an emergency of unprecedented magnitude. So we'd rather fail now, fail early, fail often, but fail forward. We need to have the same voice in advocating for additional investment. We know where the investment is likely to come, government, private sector, philanthropy. We need to have a shared voice. We don't need to put band-aids on the system. I think everyone who knows what the challenge is, it's right in their face. This is a time to put our voices together. Rather than slicing the pie, advocate for a bigger pie. We know who appropriates resources. We know where the resources come from. The whole world is listening. We can't wait until everyone is absent-minded to make the case. So if there's a challenge, be it government, be it technocrats, be it politicians, I think this is a time to have one voice and acknowledge we need additional investment in healthcare, and the time is now. We should be bold, we should be unflinching, we shall step on toes, and it's okay, because if we don't do so, the next generation will hold it against us. The next piece I just wanted to mention specifically, I think COVID has highlighted to us the opportunity to depoliticize emergency care. Once emergency care in any way is linked to politics, there's more emphasis on visibility than impact. We see a lot of politicians buying ambulances, and more emphasis is put on decoration than equipping the ambulances. It's an opportunity, but we can channel that energy into a way that really moves emergency care from one point to another. Just to highlight two very positive aspects, drawing lessons from Uganda. I think, and in many ways in the region, there's increased respect for technical input in how this emergency care needs to be structured. And I think that in many ways has led to the progress we've seen in emergency care, having a united voice and inclusive decision-making, particularly with the leadership of the ministry, to have civil society, to have private sector, to have academia, and all other inputs put on the table and welcomed into the decision-making, I think is a very big positive step. And while it lasts, we need to seize that opportunity to really further advocate for emergency care. So pivoting to where the opportunity is for SEED, I think, one, we do know that there has been a lot of shift in allocation of resources towards COVID. There will be an inevitable backlash on the system months or years down the road, because a lot of the resources that are supposed to go to continuity of essential services, non-communicable diseases, name it, have been shifted into the complex emergency management, and there's going to be a backlash. So I think this is the opportunity where everyone thinks about the today and now, also begin to think about what next, because otherwise we'll be moving from crisis to crisis. So if you ask me where the opportunity is, I think someone needs to pay attention to that before it comes back to bite us. Thank you. I'll leave it at that.
Thank you very much, Bonaventure. So yes, a very passionate call to action for coordinated advocacy and taking one voice on this. And I think there are kind of remarkable points of connection between the things that people have stated today, and I hope this will create an opportunity for all of you to reach out to each other. We will also link up this group and share some materials with all of the attendees. So let me turn now, and we'll do a quick summary at the end, but let me turn back to Commissioner Waniaye. And even before, so as we've heard from your initial response, Commissioner, Uganda chose to take a very active strategic decision to prioritize emergency care long before the pandemic. I'm curious now, looking back from the perspective of the present, how did these early decisions and actions to strengthen emergency care, how did that affect your COVID-19 response? And how have your emergency care strengthening activities sort of changed during the pandemic? I don't mean logistical things like not being able to do face-to-face trainings. I mean more, how has your strategic thinking about emergency care changed during the pandemic? Just to pick up on a few of the points that Bonaventure was making previously. So over to you. So just to summarize, sorry, how did the prior decisions to prioritize emergency care and the actions you took, how did that change your COVID-19 response? And then how has your strategic thinking about emergency care evolved in the setting of the pandemic? Over to you.
Thank you, Dr. Terry, and thank you, the previous speakers, Dr. Alenyo, Dr. Priska, and Dr. Boni, and Brot. One of by the time the COVID pandemic, the first wave of the COVID pandemic came in, this, whatever we had set up became like a base for us to really negotiate for resource allocation towards emergency medical services. And we utilized the existing operational plans, the strategic plan, to make sure that the emergency care response in the overall response to COVID is taken care of. And we managed to get at least funding towards some of the areas which we thought we are going to take much longer. Somewhat we took from Bonaventure's submission, COVID came almost like, it's a bad thing, but it came like a blessing for people to understand what emergency response means and what does it desire, what investments should be in. Still on it, it was easy to mobilize the partners because we were already having partners. We are working with Malteser International Coffee, we are working with WHO, we are working with CDC, we are working with Total and others, Chai, City Global. It was much more easy to mobilize these people to come together during the first phase of the COVID pandemic. And quickly, most of these partners had to reallocate their resources into the response to the pandemic. And that helped us essentially to have a quicker response than what we expected. The other part is on in terms of professionalism. We really, because of the previous funding which had gone into supporting the establishment of the postgraduate professional courses in Makerere and in Mbarara, we already got the products, the emergency physicians who were to support the system. And also, I think I can take it due to COVID and so on, we were able to get back also Dr. Lenyo to support the system, and she has been quite key. And I think all this was because we had already that background. Then the other part was fast tracking the call and dispatch system. We had planned and still in plan that we are going to establish 14 call and dispatch centers across the country. But when COVID came, we quickly started saying, what can we do? Our phones were ringing, some of them were getting off, you could not function. So the urgency of a call center became key, and partners were willing to help us. And we are now working with KCCA using an app which is helping us in coordination. We are establishing the first call and dispatch center at Naguru station, and also we have had one functioning in Masaka. So somewhat it is making this system move faster. And what we need now to look at, basing on the COVID-19 pandemic and the suffering which people have gone through. As you note, we have been able to pick some of these people who have desaturated from their homes, from health facilities. You find that even the ambulances are not having the adequacy to keep to the pressure. But what was advantageous is that originally we had only type A ambulances in the country, but by the set of this pandemic, we got the type B and the type C ambulances. The type B ambulances are the ones where you can be able to offer basic life support, including giving oxygen. Then the type C is where we can give the advanced life support. So we were able to get all this, and we think that going forward, we need to build on some of these investments so that we are able to spread across the country. The emergency departments at health facility level, this is an area where, again, further investment is required to make sure that all the health center floors, general hospitals, and regional referral hospitals are able to make the response as required. Thank you. I'll end it there.
Perfect, Commissioner. Thank you very, very much. So listen, we are almost at the end of our session. And what I will do is take just a moment to flag, I won't really attempt to summarize because I would be completely inadequate to the task. But what I will do is try to make an attempt to flag a few quick summary statements that we have come out with on this, a few points. So one of the takeaways clearly from this discussion is that emergency care is everybody's business. We've heard from all of you that one of the important things to understand about emergency care is that it delivers across a range of conditions, whether that be injury, complications of pregnancy, infectious disease, and whether that be a single child with pneumonia or a global pandemic, that emergency care delivers across all of these health areas. Several of you emphasized the idea that emergency care really belongs to all health areas, in the sense that some of the things we talk about as proven actions or effective actions, actually their impact decreases with delays to care. So emergency care in that sense amplifies many other investments that we make across the health system and really amplifies the impact of the rest of the health system. Given this, several of you mentioned the powerful effect, the kind of knockoff effect of early intervention and very simple and effective and cost-effective interventions. And given that, there was a strong emphasis on the need for training across all cadres. and that would include bystanders. And similarly, because we need everyone throughout the system to be able to act on these emergencies, that certain kinds of innovations like digital tools can really provide early communication and support from one level of the system to the other. We heard that leadership incorporation into this curriculum will be absolutely critical, and that advocacy and coordinated advocacy will be important, that emergency care saves lives, but we need to take lessons from the pandemic and prepare ourselves better to be ready in the emergency care system for the next pandemic. We've also heard that the pandemic created an unprecedented opportunity and willingness to coordinate and engage, and our job should be to get that message across and carry that forward. Finally, that we really need strong M&E mechanisms at every stage of the process, and that linking up to the higher level multi-sectoral agendas, so linking Ministry of Health, Ministry of Transport, and Ministry of Finance will be critical, and that incorporating emergency care services into national health packages will be one of the key mechanisms as we look at emergency care for universal health coverage. So with that, I would go ahead, I'll let the commissioner say one last word, but let me thank everyone for your time, your engagement, and it's really been quite an extraordinary opportunity to speak with you all about one of my favorite topics. So over to you, Commissioner, for the last word.
Good. Thank you so much, Dr. Terry, for passing us through this very, very important topic. And the panelists, we are very grateful for your steps, and all the participants. I bring greetings from the PS and the Honorable Minister. These are the PS and the Honorable Minister. They are great supporters of the emergency care system development in the country. And the PS would have been here, but due to another engagement, she was not able to make it. But take it that we have a good leadership at the Ministry of Health, and we think the decision is made in this summit are going to help Uganda to be another step. And we call on other countries which have not reached our level to push to that level. And we also call on countries which are far above us to share with us so that we can, as Uganda, push towards the best we can. As Uganda, we are looking at establishing a functional emergency care system that works for all people, right from the village level to the urban centers. I want to thank you, and I thank the organizers of this summit for giving us this opportunity. Thank you.
Goodbye, everyone. Thanks. We'll end the session now. Thanks very much.
Thanks for the invite.